Welcome. Hello, everyone. We'll be getting started in just a moment. As you all are settling in, please take a moment to familiarize yourself with the Zoom functionality. At the bottom of the screen, you will see a chat function. You will also see a Q&A function, as well as a show captions function. And you can use all of those during the course of this webinar. If you feel like chatting now, feel free to weigh in and tell us where you're registering in from. Please note that if you do comment in the chat, we will be able to see your name. If you want to ask a question anonymously, you should use the Q&A functionality, and you'll need to check the box that says that you want to be anonymous. Thank you. Thanks, everyone. We will start in just a moment. I also want to mention that everyone who's registered for this webinar will receive a recording of the webinar after it's finished. So you can listen attentively and not feel as though you have to scribble notes throughout the entire webinar. Welcome to those who are just joining again. We'll be starting in just a moment. Just to reiterate, if you want to say hello in the chat and tell us where you're registering in from, you can do so, but we will be able to see your name. If you want to ask a question anonymously, please use the Q&A functionality and check that you wish to remain anonymous. Hi, Wendy. Thanks for joining us. And we'll just give it about 30 more seconds. Hi, Gladys. Nice to see you. Thanks for joining us. After the webinar is completed, everyone will be getting a recording of the webinar via email. So you needn't feel as though you have to scribble everything down. Also, at the end of the webinar, we will be showcasing a number of resources that we have for more information. Hi, Beverly. Thanks for joining us. Maybe just a few more seconds. Hello, everyone. And I'm showing 101, so we're going to go ahead and get started. So officially, welcome, everyone. My name is Maria Thomas, and we are Sunday Health. And we welcome you to our webinar this afternoon. Sunday Health is a new medical practice. We're focusing on delivering cognitive care, specifically care for your thinking and memory functions. Currently, Sunday Health is accepting new patients. We are able to see patients in DC, Maryland, and Virginia. We accept Medicare Part B. We also accept cash. If you're interested after the webinar in learning more about Sunday Health's care services, or maybe even in making an appointment, we will have information at the end of the webinar for that. But this webinar is really about demystifying and defining cognitive testing and encouraging you to make cognitive testing part of your regular health routine. So our agenda includes the definition of cognitive testing, what to expect during cognitive testing, and reasons, as I said, to make cognitive testing part of your overall health routine. We also hope to have plenty of time for your questions. As I mentioned before, you can ask a question in the Q&A section of Zoom at the bottom of your screen. If you want to be anonymous, you actually have to check send anonymously, as we're showing on the screen right now. You're welcome to chat with us in the chat as well if you have just commentary or other things you'd like to offer. And if you want to see closed captions, you can click on the captioning button also at the bottom of your screen. So now on to the webinar. I'm really delighted to introduce my colleagues today. We're joined by 3 of Sunday Health's highly experienced and very knowledgeable clinicians. Dr. Amy Sanders is a medical doctor and a board-certified neurologist. She has over 15 years of experience specifically in dementia neurology. She's offered care to patients living with dementia and also to their care partners. Sarah Borchelt is an adult geriatric nurse practitioner with over a dozen years of clinical experience. And Kelly O'Connell is Sunday Health's Director of Clinical Operations and also our nurse care navigator. Kelly is also a nurse practitioner with over a dozen years of clinical experience. So as you can see, we've assembled a terrific team to share some facts with you today, and we look forward to your questions. So I'm handing it over now to Dr. Sanders.
Thank you, Maria, and welcome to everyone. It makes me very happy that you have all joined us today to learn more about brain health and cognition and how we test it. So, as Maria said, I am a neurologist, and since 2008, when I entered practice, the major focus of my career has been on the cognitive health of older adults. Let's get to it. Let's start by defining cognition. And I can do that with one word. Cognition equals thinking. So now we can all go home, right? Well, not quite. It's not quite so simple. In fact, most people think that cognition is really mostly memory. And many times when people come to see me, they come saying, "Doc, I have a problem with my memory." But when I evaluate them, I find out that something else is getting in the way of their memory function, and their memory is actually working just fine. So cognition is more than just memory, and it includes, typically, when we test it, at least 4 other major areas, and we call these areas domains of cognition. So there's attention, that's the ability to focus and concentrate. There's language, this is the ability to read and write and talk and understand what is said to you. There's executive function, which is a kind of weird, jargony term, but it's all of the things that we do that allow us to function in a kind of executive way. So long-range planning, mathematics, multitasking, abstract reasoning, all of these things we lump together and call them executive function. And then finally, there's my weakest category, visual spatial abilities. So this is things like the ability to read a map or to pack a suitcase or to look at a picture and describe what's happening in the picture, to copy a complicated diagram, to draw freehand a simple diagram like a cube. So these are all of the areas of thinking, the 5 domains of thinking that we evaluate when we do cognitive testing. Many people don't realize, they don't think about it really, but they don't realize that cognition changes over time. Indeed, many people have the unrealistic expectation that their thinking when they're in their 60s or 70s or 80s should be exactly as it was when they were in their 30s. But your knees aren't the same. Your lower back is not the same. Your skin is not the same. Your hair is not the same. So it's not so reasonable to expect that your cognition should be the same. And that's, in fact, because it isn't. And cognitive testing helps us to measure these changes over time. And if you can go on to the next slide. Yes, here we have a nifty little diagram. Down at the bottom, we have on the horizontal line, time. So all the way at the left is maybe when you're born, and all the way at the right is maybe when you turn 100 years old. On the vertical line to the left, that's our cognitive abilities. And as you may notice, when we're born, our genetic makeup is crucial for determining our cognitive makeup. Also our environment, so how far we went in school, what kind of work we did, and then lifetime experience. And all of this determines how our experience of cognitive aging is going to unfold. For a lucky few among us, there will be optimal aging and essentially no loss of cognitive function over time. This is not normal. It's certainly not pathological by any stretch of the imagination, but it is darn tootin' uncommon. What happens much more commonly is seen on the other 3 lines. Most of us undergo a process of typical cognitive aging, normal cognitive aging. And here, the main thing that happens is that things get slower. We process incoming information more slowly. It may take us longer to remember the name of that hot new restaurant or the movie that we want to see or the book that we just read. or even just the word that we want in the moment that we want it. That's typical of the cognitive aging process. What is never typical of cognitive aging is frank memory loss or frank memory dysfunction. If you leave here today with only one or two learned things, I want one of those learned things to be that memory loss is never a normal part of aging. We used to think that it was, but we now know better. So when somebody has objective signs of memory impairment or impairment in another kind of thinking, we call that mild cognitive impairment. And then dementia is just a catch-all term for when cognitive function becomes so impaired that it impedes a person's ability to live their life in their normal way. I've been using a number of terms somewhat generally. I'm going to define them a little bit more specifically now. Cognitive testing is an umbrella term. You can think of it as a continuum, everything from a very short test that may take just a few minutes to do, all the way up to a very in-depth type of cognitive evaluation called neuropsychological testing that averages 3 or 4 hours under most circumstances. Cognitive screening is, go back one if you would, in the slide. So cognitive screening is a small part of cognitive testing. The cognitive assessment really constitutes a much bigger part. And you can see that depicted there in that graphic with the 2 circles. Okay, so next slide, please. So what is a cognitive screening? It is a short test, usually just minutes to administer. Often happens, although not always, but often happens during a routine visit, maybe done by a nurse or a medical assistant. It is a required component of the Medicare annual wellness visit, although it doesn't always happen there. By definition, a screening test is an early warning system to pick up signs of a possible underlying disease before symptoms have appeared. Also, by definition, it should never be used to make a diagnosis. And you may have had a cognitive screening in the past. Oftentimes people are asked to draw a clock for me. And many people are puzzled by this. A clock is a qualitative test, meaning that your clock is good, your clock is not so good. So there's no quantitative way that groups of people's clock expertise can be compared. But when we look at a clock, we can often tell whether it's normal or abnormal. So on the left, you have a normal clock. Person was asked, put numbers in this circle to make it look like the face of a clock. And then they were asked to show the time as 10 minutes after 11. Moving one to the right, we have someone who has mild cognitive impairment. And here, the clock still looks pretty good. All the numbers are there, maybe not precisely where they should be. And the hands are not quite as precisely drawn as they were on the normal clock. Moving again to the right, here we now have somebody who has a mild or moderate dementia, something like Alzheimer's disease. And here the clock is not normal anymore. You can tell. The numbers are eccentrically placed, some more than others. Number 10, completely missing, and there are no hands. There's a sketch of an idea that might have been hands, but it's not hands. And then all the way to the right is somebody who has a late stage of something like Alzheimer's disease, and their all representation of the clock face has been lost. So what is a cognitive assessment then? Well, this is a much more in-depth evaluation of those 5 domains of thinking that I mentioned. Attention, memory, language, executive function, and visual spatial ability. Takes a minimum of an hour, usually requires a separate dedicated appointment and typically a referral, because usually these tests are done by specialists. A neuropsychologist is a psychologist with a clinical doctoral degree who has done beyond the doctoral training to learn how to examine the brain as an organ of thinking. And a cognitive assessment is an essential, though certainly not the only, component of making a cognitive diagnosis. So what do you get out of an assessment? The testing certainly helps me to make a diagnosis, but it has benefits for you too. It helps to give you a sense of how your thinking is compared to people who are similar to you in age and educational background. Helps to identify where your thinking is strong and where it's weak. And sometimes we can figure out ways to make the strong areas bolster up the weak areas. And finally, it can help us to determine whether there are other aspects of your medical background that is contributing to the cognitive changes that you think you might be experiencing. So this could be everything from other medical conditions, stress, anxiety, depression, or even medications that have cognitive side effects. So that is me finished, and I'm now going to turn it back to Maria.
Thank you so much, Amy. Amy, if I could just interject one quick question before we keep moving on. We had a great question in the Q&A about what is the difference between dementia and Alzheimer's disease?
Oh, yes. Thank you, Maria. That is a really, really important question, and I'm so glad that somebody has already asked it. Dementia is a catch-all term. It is non-specific. There are more than 100 diseases that can cause dementia. Dementia just means that cognitive impairment is present and it is severe enough that it is impairing a person's ability to live their lives and take care of themselves in their normal way. Alzheimer's disease is the big kahuna of the diseases that can cause dementia, accounting for, by various estimates, somewhere between 60 and 70% of all cases of dementia. Most of them caused by Alzheimer's disease. Also, there's something called dementia with Lewy bodies. Famously, that's what Robin Williams had. There is vascular dementia. Famously, that's what Margaret Thatcher had. And there's something called frontotemporal dementia. Famously, that's what Bruce Willis has. Those are the big four. There are probably more than 90 others, other diseases that can cause the dementia state, which is a catch-all term.
Amy, that was great. Thank you. And there is a follow-up already, and I'm going to just add that in right now, which is what is the difference between MCI and dementia, mild cognitive impairment and dementia?
Okay, mild cognitive impairment we think of as a possible pre-dementia state, and that especially applies when memory dysfunction is part of the mild cognitive impairment. It isn't always. All mild cognitive impairment requires is that a person is aware of a problem. Doc, my memory is shot. That's a subjective complaint, and that's required. There has to have been testing that demonstrates objective impairment in at least one type of thinking: attention, memory, language, executive function, and visual spatial ability. At least one of those areas must be objectively impaired. Yet a person must be, and this is part of the definition for mild cognitive impairment, still taking care of themselves, living their lives in their usual fashion. This is not to say that they might not be finding some things more difficult than they used to be, but they're still able to take care of themselves. If memory is involved, on average, about 12 to 15% of people might progress to early stage Alzheimer's disease in any given year. That is not cumulative. So if you've had MCI and you've had it for 12 years, your chance of progressing is not 12 times 12, it's still just 12%. So MCI is possibly, for some people it is, a pre-dementia state. It can be caused by all sorts of different things, though, and memory is not always involved. And sometimes, and this is especially the case if something obvious is identified, a metabolic abnormality, kidney failure, for example, or a lifestyle problem like not getting adequate restorative sleep. If those things are treated, the MCI can actually revert back to normal. So it is a fluid state that is thought perhaps to be something that people experience in transition from normal cognitive aging to the dementia state.
Thank you so much, Amy. We are going to invite Sarah Borchelt to share a few things with the group right now. There was a question that teased this up perfectly, Sarah. There's a question that is, when is sort of the appropriate age to start cognitive screenings? And this particular person said that she has not yet had them as part of her Medicare annual wellness visit. So before we turn to Sarah, before we turn to Sarah, I think we were going to run a short poll, right, Yuritsa? Okay, so this is the question. And if you're seeing on your screen an answer to the question, has your doctor ever talked to you about cognitive testing? You can answer yes, no, not yet. I've proactively asked about testing, and we'll see what folks in this group are experiencing. Okay, we'll give everybody a minute. And are we ready to pull up the results? And I should mention that the poll responses are anonymous. So we will just look at them anonymously in the aggregate. I'm not actually seeing the poll responses yet. Oh, here we go. There they are. So for many people in this group have not yet had a cognitive test. A few have, maybe about a quarter of you have, and some have been asking proactively. And so I'm going to turn it over to my colleague, nurse practitioner Sarah Borchelt, and she's going to talk a little bit about cognitive testing and when to get it and how to think about it. Sarah?
Awesome. Thank you so much, Maria and Amy, for all of that wonderful information. Just as a quick recap, cognitive testing is an umbrella term, and that includes cognitive screenings, which are simpler, shorter assessments, and cognitive assessments, which are a little bit longer, more comprehensive. You can go ahead on to the next slide. Awesome. Thank you. So here's some interesting statistics around cognitive testing. 3 in 5 adults actually say that if it was recommended to them, they would have a cognitive evaluation. Unfortunately, only 16% of older adults, however, have actually received that cognitive screening. And as of now, less than half of primary care physicians say that this type of cognitive screening is a routine part of their protocol for their patients. So why is this important? First things first, it's very important to establish a baseline. This means knowing where you are now in order to have data for future comparison. This is important for you, but also for anyone in your healthcare team, doctors or nurses, but also family or friends. Consider how mammograms and colonoscopies, even annual wellness visits, are routine parts of our healthcare. This is similar, collecting data as a snapshot of now in order for future comparison. Cognitive testing can also help us understand what our individual risk factors may be for cognitive changes, and also to learn about what you can do to maximize your health here and now. It's important because it can open up a conversation between you and your family, you and your healthcare team, to help empower you in your health and things you can do now. As we've said, cognitive testing is a more comprehensive thing, and so it can identify some underlying issues that may contribute to cognitive changes, but may not actually be true dementia as Amy defined. And so this cognitive testing can help identify areas in your life or in your medical health that you can focus on to promote better health. What are some examples? A low B12 level, or vitamin D deficiency, or thyroid changes, anxiety and depression, poor sleep. These are all things that can affect our cognition, and we may not connect those dots, and a cognitive testing can bring that to light. Cognitive testing is also very important for helping us access the right care at the right time. And so if there were a diagnosis of mild cognitive impairment or dementia, as Amy has defined, this can help us get access to treatments earlier on. treatments that fortunately now there are some novel therapies available, and they're designed for the earlier stages, either MCI or the earlier stages of Alzheimer's disease. And so, as the saying goes, earlier is better in this regard. And it's not that there's nothing to do later down the line. It just gives us probably more options in that regard. And finally, planning. In healthcare, we love to plan, but I think when it comes to cognitive health, incorporating planning as early on is better. I don't think too far-fetched to say that our independence and our safety are two of our more treasured assets in this life. And if we know earlier on that there may be some cognitive concerns or just areas we need to focus on, this can help us make plans, whether it be regarding finances or advanced directives and living wills, or plans regarding what you want to change in your health. It can also be things for safety, such as safety in the home or driving safety. And so it allows things to come into the light that may not have been in the light for you to maximize both your health and your safety and independence over time.
Thank you so much, Sarah. We have a couple more questions here in the Q&A. Again, if anyone wants to ask a question, feel free to submit it in the Q&A area at the bottom of Zoom. If you would wish to be anonymous, you must select submit anonymously. I do want to just recap a couple of really important things that Sarah said, and maybe Amy, come back to you with a piece of a question. Just to remind everyone, Sarah said that you can get, and actually Medicare does require cognitive testing as part of the annual wellness visit. Unfortunately, many PCPs do not do it. Why they don't do it, is up for discussion. Could be they don't have time, could be they don't feel trained. Whatever the reason, many people are not getting cognitive testing when they should be. Amy, the question coming back to you is specifically a question of what is the appropriate age to start to get a baseline cognitive test?
I'm sorry, I was on mute still. So I was answering the question and there I was on mute. Anyway, I love this question. If I were king of the world, not likely to happen, but if I were, everybody would have cognitive testing when they were 35 years old. Why do I pick 35 years old? Well, it takes almost until our mid-20s for our brain physically to become fully mature. This is why teenagers don't function like people who are in their mid-20s or older. Their brains are still not yet mature. And then I would add, 5 to 10 years worth of time to gather some lifetime experience. And then I would test people at around age 35, because that's really the peak of their lifetime intellectual or cognitive abilities. Everything is downhill from there, although it's downhill in a very slow and gradual way. So absolutely, I think that everybody should have a baseline evaluation when they are about 35 years old. The real question, though, is at what age should older adults start having cognitive testing? Well, one reason that the Medicare wellness visit is supposed to include cognitive testing is because there's a lot of medical research that demonstrates how important cognition is to aging well, to taking care of oneself, to managing one's other medical problems. So absolutely, positively, not later than about age 65. If your practice where you go for your Medicare annual wellness visit test is not doing that test, you might ask them if they could do it. And if they can't or won't, maybe ask them where you could get such testing, because you believe that it's very important. If people start asking and demanding this kind of testing, I think that it will happen more frequently. It does take some time. And one thing that is well recognized now is that primary care practices, or PCPs, are very, very much under the gun in terms of time. They have many patients and they're not permitted much time to see each of them, which can make getting this kind of testing a bit challenging. There are some ways to do it online, sort of as a self-test. Those are not very reliable, though. I hope that answers the question fully enough.
Thank you so much, Amy. I'm going to keep you on the spot for a moment before I bump over to Kelly in a minute. I do want to say, just for myself, I think it's interesting that we as a society have come to accept and embrace the idea that on a regular basis, women get mammograms, or we all, after a certain age, regularly get colonoscopies. And so I think what part of what Sunday Health is trying to encourage here is that just as you do for other parts of your body or other organs have regular testing and comparisons to a baseline, so we would wish to encourage that for your brain, and hence the emphasis on getting the brain baseline. But Amy, while you're still here, there was a question specifically about the drugs, and Sarah referred to the fact that no longer do neurologists like yourself have nothing to offer, that there has been significant change in the dementia landscape in recent years, including the introduction of 2 new drugs targeted specifically for people at the earliest stages, MCI or early dementia. Could you mention the names of those drugs, Amy? And also the specific question being asked is, do you need an affirmative diagnosis of Alzheimer's to be considered for those drugs?
So yes, the short answer is yes, you do need that kind of affirmative diagnosis, and there is a very important reason why. As Maria and Sarah mentioned, there are 2 new medications on the market, FDA approved. One was FDA approved in, I think, June of 2023. One was approved quite literally last month. The first one, the one from last year, the generic name is lecanemab. The brand name is Leqembi, L-E-Q, I think U-E-M-B-I. It's a Japanese word for something meaning beautiful, elegant, something like that. It's a Japanese pharmaceutical company that took this drug to the FDA, hence it has a Japanese name. The other drug, more recently approved, is generically known as donanemab. Its brand name is Kisunla, and I have no idea what that word means. I don't know if it has any particular meaning at all. Both of these drugs work by a mechanism called they're monoclonal antibodies. So they circulate, they're given every 2 to 4 weeks by an intravenous infusion. So you can't just take a pill. You have to go to an infusion center and have your infusion. Lots of medications are given this way now. Turn on your TV tonight and look at the ads, and you will see, I'm sure, many medical ads about drugs that are given by infusion. And in order to get this drug, you must have a diagnosis of mild cognitive impairment felt to be due to underlying Alzheimer's disease or the early stages of Alzheimer's disease. The drug is given to you via an intravenous infusion. It circulates through your bloodstream. It crosses into your brain and then goes on a targeted mission to find amyloid protein, abnormal Alzheimer's amyloid protein. Abnormal amyloid protein is one of the 2 main proteins that cause Alzheimer's disease. We're pretty sure that that's true. We're not entirely sure. We haven't worked out completely yet how aberrant amyloid protein causes Alzheimer's disease, but we know that it does. And these drugs can clear that abnormal amyloid protein out of the brain. So they're fairly powerful drugs, at least in a physiological way. Somewhat less is known yet about just what impact they have on cognition. But in general terms, for lecanemab, the first one that was approved, Leqembi, it was thought that taking Leqembi for somebody with mild Alzheimer's disease could be the equivalent of at least 5 months worth of additional reasonable cognitive functioning. And boy, if you're planning a family wedding or a major trip or something like that, having those extra 5 months could really, really be a big deal. What are the side effects? I mentioned that it's important to know for sure that somebody has the condition that these drugs are designed to treat before giving them, because they do have some fairly significant side effects known as amyloid-related imaging abnormalities, or ARIA for short. They can cause brain bleeding, they can cause brain swelling. Most of the time, that's manageable. But these are pretty significant side effects. So we want to be sure that this drug is not being given to people who do not have the underlying condition that the drug is designed to treat. So yes, you do have to have an affirmative diagnosis. And there are very specific requirements about how that affirmative diagnosis is determined. It is not sufficient to have cognitive testing or to have a physician say, this patient has Alzheimer's disease.
Thank you so much, Amy, for that thorough answer. There are some more questions. I want to acknowledge that we're reading them all and we're getting to them. I'm going to ask my colleague, Kelly O'Connell, who's our Director of Clinical Operations and also a nurse practitioner, to tell you a little bit about how the process actually works at Sunday Health, and that will answer a couple of the questions that I'm seeing in the Q&A. So turning it over to you, Kelly.
Great, thank you, Maria. This is an excellent question. And so here at Sunday Health, things start with a phone call with me, our nurse care navigator, during which I ask you to share what, if any, concerns you are having right now, as well as describe any medical history or family history that you'd like to share. And then we review what our services are to make sure that they're in alignment with your needs and goals. And if so, review our process. So after this phone call, if you're deciding to move ahead and schedule, I would send you an email with details of preparing for your first appointment, which includes a computer-based interactive assessment, which folks have reported can be quite fun. It also includes 2 screeners of mood, because we know that there is a strong interrelationship there between our mood and our cognition, and vice versa. After you've completed that, you will have your first telehealth visit, which is with one of our nurse practitioners. You're having the opportunity to meet Sarah now, and our other nurse practitioner is Mallory Quinnett. During this first visit, which we call a brain health assessment, you will have a comprehensive review of your medical history and your medications, an in-depth discussion about what we call a cognitive history, during which you'll have questions about your education and occupation. And then there'll be additional testing completed regarding your cognition and mood, potentially about sleep as well. And after that point, you'll receive those results, and those results will determine what the next steps are in the process. So those things might include labs and imaging, and then ultimately moving on to what we call a brain health plan visit for individuals who do not have any symptoms of cognitive decline. And then for those people that do have symptoms of cognitive decline identified during their initial appointment, they would go on to have an appointment with Dr. Sanders for neuropsychological testing. Now, before the neuropsychological testing, we ask the patient to identify a family member or friend who can contribute to their care by providing information about how they are in their everyday life and what, if any, role cognitive changes may be having. And that information is hugely important in understanding, again, how the person's cognitive changes are impacting their day-to-day life. And Dr. Sanders will incorporate those answers in her overall report and interpretation of the neuropsychological testing itself. That testing takes about an hour long. And then during a next and final visit, which you'll have with Dr. Sanders, you'll receive the results of the neuropsychological testing, as well as any recommendations. These recommendations could include labs and imaging, as well as medications or changes to medications that you're currently on. as well as recommendations for things regarding sleep and more.
Thank you so much, Kelly. I want to remind everyone listening that at Sunday Health, we are licensed to practice in DC, Maryland, and Virginia. We are taking new appointments if you're interested in that. Here's some information which we'll show again. This is all on our website. We do have some unanswered questions, though, so we're going to come back to that. And by the way, Sunday Health does not require a referral. I don't think anyone asked that, but I'm going to share that. Amy, I'm going to direct one in to you, which is somebody has asked, what is required for an affirmative diagnosis of Alzheimer's disease?
All right, coming off of mute, and here's my, there I am. Okay. So yes, thank you for asking that. I queued it up for you and you did exactly what I hoped you would do, which was pose the follow-up question. So these days, generally speaking, it is necessary that one have evidence of deposition of excess amyloid protein in the brain. You can't get that through cognitive testing. You cannot get that via an MRI or a CAT scan because MRIs and CAT scans cannot see abnormal amyloid protein in the brain. In order to see abnormal amyloid protein in the brain, you need a PET scan. So a PET scan is kind of like a glorified CAT scan that involves the injection of a radiographic tracer into a vein in your arm. Then you go have coffee while the tracer circulates through your body into the brain, where it binds to, this is what the tracer is designed to do, it binds to abnormal amyloid protein. So just like the monoclonal antibodies bind to amyloid protein, so too does the PET tracer. PET tracer doesn't have any therapeutic benefit, but it certainly has diagnostic benefit. It allows us to make a diagnosis, sort of, mostly. So the PET scan can allow us to see abnormal amyloid protein in the brain. And you must either have a positive amyloid PET scan or other evidence of excess amyloid in the body. The way that, as of this moment, is FDA approved, that non-PET scan wise, to get that evidence is through a lumbar puncture, more familiarly known as a spinal tap. Most of the time these days, that's done in an interventional radiology suite under fluoroscopic guidance, so that the person only has to be punctured once. It can be done bedside, but there it's a little bit more of a so-called blind stick. And then the cerebral spinal fluid levels of amyloid protein and a few other things as well are evaluated, and you have to have certain levels in order to meet criteria for getting one of these medications. In the near future, most people say this is going to be in years. I'm maybe even measured in months. We will have blood tests that will be able to do this confirmation of abnormal Alzheimer's disease pathology in the body. There are several blood tests already available. They're not yet FDA approved to be able to suffice for making the diagnosis of Alzheimer's disease in order to give somebody one of these medications. But we're going to get there soon.
Thank you, Amy. A couple of questions have come up that I'm going to take involving insurance and other questions like that. First, I wanted to remind everybody that Sunday Health's care services are today offered virtually. So that means that your interaction with Dr. Sanders or with Kelly or Sarah would be just like this via Zoom. That makes it very convenient for you and also makes it quite private. And we also have very little wait time as a new practice. So if you're looking to get evaluated soon, we can accommodate that, provided that you live in Maryland, DC, or Virginia, and that you're covered by Medicare Part B. Someone had asked if most insurances cover the more thorough cognitive assessments. I don't think we can speak on behalf of most insurances. We can tell you that Medicare does cover this type of testing and assessments. And if you have a Medigap plan or a supplemental plan, then obviously that would cover the 20% that would otherwise be due from the patient. But if you have a commercial plan at this point, you would need to check with your commercial plan provider. We do offer self-pay options. You can read about those on our website. We have both a kind of basic brain health test option and then the more comprehensive option as well. And another question was, does Sunday Health compensate doctors who refer patients? And the answer is no, we do not compensate doctors who refer patients to us. There was a question a while back we didn't get to, Amy. I'm going to come to you, and then another one that I'm hoping that any of the clinicians can take, including Sarah and Kelly. But Amy, the question earlier was somebody was speaking about, I believe, a relative who has maybe some short-term memory problems whereby they repeat the same story over and over. And the question was, is that normal cognitive aging or reason for concern? I'm paraphrasing, forgive me, I'm not reading the question directly.
Sure, that's a great question. And it speaks to repetitiveness. So everybody repeats themselves every now and again. I've probably repeated myself several times already in this webinar. So some degree of repetitiveness is normal, happens in the normal course of events. A pattern of unusual repetitiveness, I think, should be cause for concern. It is nowhere near a diagnosis, and it may be due to something that is not a cognitive problem. Could be due to bad sleep or stress, anxiety, something like that. However, in many cases, it is an early warning sign, kind of a canary in the coal mine, if you will. Terrible metaphor. I apologize for that. But repeating oneself, telling the same person the same story over and over again in an unusually short period of time, or asking the same person the same question repeatedly in an unusually short period of time, that may be an early warning sign of short-term memory dysfunction. And I would argue that in every case of that kind of repetitiveness, it is absolutely worth being seen. And please tell all your friends that that's the case.
Thank you, Amy. I'm sorry there's a short delay and I'm coming back onto the video. I did want to acknowledge that we saw the question, a very specific situation involving a couple of different drugs. I want to suggest to whomever asked that question that maybe you email us at hello@sundayhealth.com and we could take that one offline because it is quite specific. There was another question about that I'm going to open up to any of the clinicians and Kelly or Sarah, if you want to kick it off, or Amy, whoever wants to kick it off. It was about, again, I'm paraphrasing, suggestions for non-pharma or non-drug interventions.
I can start, and Amy, please chime in. So I love this topic because I think our health is multifactorial. We like to think about things a little more holistically. And so one of the approaches we've taken to addressing cognitive changes that we're seeing is looking more extensively at what is going on, including your medical health, but in other areas of life as well. So how are you sleeping? How are you resting? How are you eating? What are you eating? What's exercise like? What's movement like in your life? Or what are any barriers to that? How's your mood? What are things that affect your mood? Has it been changing? And what are your social connections like? There's a lot of good evidence to show that each of these areas have pretty significant impacts on our cognitive health, individually and collectively. And so we like to hone in on things that may be areas of concern within those areas. So helping people identify, okay, what are my barriers to exercise? How could I improve that within reason for my life, and what's going on for me, or what's going on with my sleep, and how can I impact that? And so while I don't have a bulleted specific list that you could maybe take home with you right now, I think those are some areas I would really encourage you to look at for your own life, to think about as affecting cognitive health. And they are things we specifically try to focus on for each individual. I hope that's helpful.
Thank you,
So I'll chime
Sarah.
in, also just to talk briefly about non-pharmacological approaches to caring for somebody even after a diagnosis of some sort of dementia has been made. Used to break my heart when people would say, well, there's no point in my going to the doctor because the doctor can't do anything. Well, for a long time, our treatments, our medical pharmacological treatments were not so great. It's true. But boy, there are ways that we could help people. So helping people, care partners, and patients themselves figure out sort of what is most important, where are the problems, and how to respond when there is a problem. So imagine that grandpa gets agitated as the day winds down. A very familiar phenomenon to people living with dementia. It's called sundowning. And, there are ways to ameliorate sundowning, to make it a little bit less intrusive into life, to make it a little bit less of a problem. And, we could do a whole webinar just on that topic alone. So that's just one example from many that we could discuss of ways that we can help even after somebody has received a diagnosis of a disease that causes dementia. It's why I get out of bed in the morning.
And we're so glad you do, Amy. The questions continue to roll in, so I'm going to continue. We had an interesting question that was submitted ahead of time that, Amy, I am going to bring back to you. And the question is, if an elderly relative is given a psychological evaluation or other cognitive test, can the doctor have her put into a facility?
The short answer to this question is, oh my goodness, no. At least not in the kind of cognitive assessments that we do. Obviously, if somebody is suicidal, that's probably the main thing that would get somebody admitted to a psychiatric facility. But again, one reason that I get out of bed in the morning is to help my older adult patients with cognitive impairment live their best lives. And that does not mean consigning them to an institution. We want to do everything that we can, working with our patients and their care partners, to maximize their safety at home. There are ways to do that so that they can live their best possible lives for as long as possible, and thrive without being consigned to an institution. That is always an option of last resort. Sometimes it does become necessary, but there are many, many things that we can do before we get to that point. And we want to push that point off into the kick that can down the road as far as we possibly can. So the short answer is no. We're not going to consign anybody to an institution one moment earlier than necessary. Also, we do not have that power. That would ultimately then be determined by the rest of the family and circle of loved ones.
We're going to continue with the questions. I do see a couple of people having to drop off, and so I just want to take this opportunity to remind everybody that you will be getting a recording of this webinar. There's also additional resources on our website under Sunday Insights at the top of the page. We have a number of blog posts, many of which were authored by Dr. Sanders, that speak to some of the questions that have been asked here. The next question, Amy, is, can you speak to the genetic piece of dementia? My understanding understanding is that later onset of dementia is less likely to be genetic, speaking from a history of grandmother and mother with later onset dementia. So this person is asking about the genetic element of dementia.
So yes, there is one. In fact, there are two. So for some dementing diseases, Alzheimer's disease and frontotemporal dementia especially, there are genetic mutations that carry destiny. In other words, if you have one of these genetic mutations, and you would have it when you were born, your destiny is that you're going to get Alzheimer's disease or frontotemporal dementia. Those are very, very uncommon, and they tend to cause people to get sick younger than usual. They are the main, one of the main things that can cause early onset Alzheimer's disease, which is by definition Alzheimer's disease that kicks in when a person is younger than age 65. There is something that is called a vulnerability, not destiny, but vulnerability, polymorphism. So it's not a genetic mutation. It's an area of the genome in a particular gene called apolipoprotein E, or ApoE for short. There's a particular little spot on that gene called the epsilon allele. Allele just means spot in the gene, where you can have one of three different varieties of genetic material. And one of them is neutral, doesn't affect risk. One of them is probably protective, not 100% sure, but pretty certain. And the other one is, for all intents and purposes, known and everybody believes is something that causes increased risk of developing Alzheimer's disease. So not destiny. You get one of these alleles from each parent. So you can have two bad alleles associated with risk, and live into your mid-90s and have normal cognitive function. How do we know that? Because those people have been identified and studied. They've probably got some other factor that is protecting them from the bad impact of having two versions of this vulnerability enhancing polymorphism. We don't yet know what that protective factor is. So ApoE testing, that's vulnerability and increased risk. Roughly 25% increased risk of developing Alzheimer's disease if you have a first-degree relative, that's a parent or a sibling, who had the disease.
That's very helpful. We're going to try.
Complicated topic.
Yes, indeed. We're going to try to squeeze in two more questions quickly. Since you were just talking about testing, Amy, could you touch very briefly on the new blood test? Someone is asking about effectiveness. Maybe you could just say on what they are and then just a few quick words about them.
Sure. There actually is a bevy of new blood tests for Alzheimer's disease. Ones that you may have heard of would be an amyloid ratio. So that compares the level in your blood or cerebrospinal fluid of normal amyloid to the pathological Alzheimer's disease causing amyloid. And if your ratio is elevated beyond a certain level, then it's thought that you have more of the bad kind of amyloid than you should have. The blood tests that have been making the news recently both actually test tau, TAU. That is the second protein that goes wrong in Alzheimer's disease, kind of goes rogue. And there are two blood tests for tau now. One of them, called p-tau 217, is thought to be the more effective of the two. And in a number of studies that are now being published in the medical literature, p-tau 217 has comparable diagnostic ability to the levels of tau in the CSF, the cerebrospinal fluid. Cerebrospinal fluid testing already has FDA approval. The tau tests do not yet have FDA approval. My understanding is that under certain circumstances, Medicare may now be covering those tests. I do not yet have independent verification of that fact, but things are changing. And even if Medicare or a commercial payer does not cover the blood tests, they are in any case going to be dramatically less expensive than having a spinal tap or having a PET scan.
Thank you. I'm afraid we don't have time for more questions. I do want to point participants to our website, sundayhealth.com. At the top of the website, you'll see a link to Insights. There are a number of articles there, some authored by Dr. Sanders, that include answers to some of the questions that have been asked that we didn't get a chance to touch on, the relationship between mood and dementia, for example. Also a quick article about the blood test that Dr. Sanders was just talking about. So thank you all for participating. Again, we are Sunday Health at sundayhealth.com. We have a number of resources available to you. You've seen a portion of our care team and clinical talent here today. If you are interested in following up with us, please reach out to us either by phone at this number that you see here on the screen or via email, hello@sundayhealth.com. We are accepting new patients, no referral required, and we do take Medicare and we do take cash. And again, we thank you all for attending. And we wish you well with the rest of your week. Seeing the reminder here, forgive me for jumping back in. We do have a presence on all of the social media channels. So if you'd like to follow along and continue to get information from Sunday Health, you can find us on Facebook and on YouTube. And again, as I mentioned, our Insights area of our website, which is our blog. So thank you again all for attending, and we'll look forward to hearing more from you.